Awesome. Okay. So very happy Father's Day again to my own dad. Hi, Pops. And all the Father's Day, all the fathers out there, wishing you a very happy Father's Day. And Glenn, as you are getting set up, I will jump in with our introduction. So, as many of you know, and maybe you don't know, those joining us on YouTube after, Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs in the US and outside of the US. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So, Glenn, we are still in a lot of the same situations that we found ourselves last week, yes? And typically you start off by telling us what's changed in the US, around the world, and the hot spots seem to be jumping around. We're hearing a lot about Arizona and Florida. Can you tell us what you're seeing?
Yeah, absolutely. Let me share my screen. I will share desktop. All right, so yeah, we let me move this a little bit over. So as you can tell, we have started going back up. I mentioned, I think last week and the last couple of weeks, that now that we've come from under lockdown, we were at our floor back then. So now we're just going back up. I think we're probably going to continue going up through the fall, depending on what states close before then. But I don't think there's a big appetite to close in July or August for many states. So it might get a little bit tricky. We will see. They might be forced to based on just hospitalizations and stuff that we might see. But a lot of epidemiologists are thinking for sure come October, November, December, the country's probably going to need to lock down again. But based on this curve, you can see that already we're starting to come back up again. So I've been tracking weekly cases, and there were 177,000 newly diagnosed cases over the last week. And so we are starting to go up in a meaningful way. It's not as much as when we first started. You can see that R value when we were first starting before the lockdowns was a lot steeper than we are now. But we're still now it's approaching exponential growth, and it could be even higher because you see that the black line is a 7-day average. It's a moving average, and so you can see that in the recent days we're starting to hit high numbers. In fact, when you look at the highs that we had back in April, June 20th, so yesterday was almost as high as some of the highs that we hit back in April. So probably within the next week to two, we will get some days where we are at the same level as we were back in April in terms of the total number of new cases diagnosed per day. So we're already approaching that again. So that's very disappointing. Good news so far is that the death rate right now hasn't caught up yet. So the death rate has, as many of you know, had been going down for a while. We know that once cases are diagnosed, because we're testing a lot more than we were before, then it could be another week until we start seeing increased hospitalization, maybe 1 to 2 weeks. And then after that, we'll start seeing an accumulation of deaths. So right now, the uptake that we just saw, that was very clear over the past week, it might take another week or two before we start seeing it in the data. When looked at the US level, at the state level, we can already start seeing some of the changes. Before I go much further, I just want to show, so testing is this weird thing that we're going on. So originally, the Harvard Global Health Institute was suggesting that we should be aiming for 500,000 tests per day. The problem is a lot of people are getting duplicate tests. They should be. So for instance, healthcare providers need to be tested weekly, because if they get infected, they don't want to infect all of their patients. And so there are a lot of people in society that really need to be getting tested weekly. Anyone who goes to any of these protests needs to be getting tested within a week of going to a protest. Anyone who's interacting with other people should be getting tested more regularly. But what this means is we have no idea how many people are being tested. So it could just be that there's a small number of people being tested frequently. And that's really not as good for us in terms of looking at the spread of the disease if we had a lot of different people that were being tested. And so this is an ongoing worry. One way of looking at this is the positive test rate, the percent positive. So in the Northeast, our numbers on average tend to be really good. So when the numbers are down to 1.5%, then that means that that we are testing people who are asymptomatic, because if it was a higher number, then it means that it's more likely that just the symptomatic people are being tested. And indeed, that's what we're seeing in the South and the West. The Midwest, we're also seeing a little bit that the numbers they were going down, but they're starting to level off. But we see in the South, the numbers are starting to go up. Even though the testing has been about the same over the last week or so, the percent positive is going up. Both the test rate and the positive percent rate are going up, which is disappointing. If the test rate were going up, the percent and the number of true cases were the same, then you'd expect the percent positive to go down as a proportion of them. So the fact that the test rate and the percent positive, or the percent positive is slightly going up, but the test rate is going up, means that we truly are finding more people, that it's not simply an artifact of testing more. So next, in terms of positive cases, so you can see the Northeast continues to come down, which is great. The Midwest was going down. Now there's maybe starting to come up. That might be a little bit of noise, but they're not really continuing down as aggressively as they were, which is disappointing. The South, this is what's really driving what we're seeing now. The South is really starting to come up. The shape of that curve, you can see, is much more apparent now when we look just at this one region. They're starting to go up. Although it's not quite as steep as it was at the beginning, like when the Northeast was hit in March. This slope of the curve is still quite a bit steeper than what we're seeing in the South, but the South this is not under control. They're not testing enough, as you can see from the past slide, so they are in trouble. And then in addition, as previous weeks what I talked about when I showed you the medical geography maps, in the South, they tend to be at higher risk for a variety of reasons, including comorbidities, including the amount of poverty that's down there, including age distributions. There's a lot of risk down there. So we're probably going to be beginning to see more severe cases. It might take a little bit of time, because typically what we're seeing is the ones who are going out are the ones who feel like they are maybe more invulnerable. They may be the younger ones, the ones who feel like they're at lower risk. But then the problem is, as they get infected, they're going to go home and then infect their households. And so then when they go home, the ones living at home are probably at higher risk. So they might be older people or other people who hadn't been venturing out because they felt it more at risk, but now they're going to be exposed by the people living in their households. It's the same thing we saw in the Northeast and in other parts of the country. The current hotspots are California, Arizona, Texas, North Carolina, South Carolina, Georgia, and Florida. You can see there's some other red ones where there have some cases that they're still dealing with. Even New York, again, it's not out of the woods yet, but they're dealing with it well in terms of they have contact tracing. So these 716 people in New York, every single one of them that is test positive, they have a team of contact tracers who go out and contact them, try to identify everyone who they might have come into contact with. So they're doing a good job of making sure it doesn't go back up again. Whereas in much of the rest of the country where the contact tracing is poor and the testing is poor, it's just a free-for-all, and these people are getting infected and there's not much we can do about it. So let me dig into Arizona. You see that Arizona was one of these hotspots. People have been looking at that for a while. So what we're seeing is that the daily tests are going up. And so some people are saying, oh, well, maybe it's only because we're testing more that we're seeing more cases. If that were the case, then if you look on the top ribbon is sort of the number, the percent positive of the tests from March 29th all the way through June 14th. And if it were simply the number of tests that were the reason that there was more COVID diagnosed, then you'd expect the percentage of positives to be going down, because as you test more, then you'd be capturing more of the population. But instead, Arizona continues to rise, both in terms of the number of tests and the percentage that are positive. So what we're seeing here in terms of the total new positive cases, this is real, and this is very steep. And this is reflected in the hospitalization. So the number of people that are going to the hospital now is getting steeper as well. It's climbing. And again, the black line is a 7-day average, I believe. Yeah, 7-day average. And you can see that as we go forward, these lines are sticking up way above that black line. So most likely what we're going to be seeing is an even steeper rise in Arizona over the next week. Death rates have continued to slowly, except for this small amount in May. Well, not small there, but there was a slight increase and then it went back. You can see that over time, there's been sort of like this steady increase in death. Well, guess what? If the hospitalization rates are starting to go up like this so fast, it's probably going to follow with a steeper death rate in the coming weeks. We can talk a little bit more about the infection fatality rate and other things we've learned about that a little bit later today. But before I go on, I'll just say, I'll also go into Florida. So Florida here was another example of a hotspot. They're really one of the leading states at this point. Texas and Florida are really a big source of the hotspots right now. And so I'm also going to dig into Florida. Florida also, the weekly tests were increasing, but you see that recently it started to level off. It was somewhat flat. And yet, despite the flattening of the number of tests, the percent positive has dramatically started going back up. The total number positive has been going up. Deaths have stayed about the same, but like I said, deaths don't immediately follow the next day. There's typically a lag. And particularly, like I said, what's driving this, or at the beginning, so back in March, when people were first getting infected and the hospitalization rates were going up so steeply, so quickly relative to when people were first getting diagnosed with the test. Can you mute that? Becky, can you please mute all? All right, so I'm assuming you can hear me now. Okay, so if you can't hear me, then Becky, do something, but I'm assuming you can hear me. All right, so great. So what we're seeing here, so what I was saying is that back in March, we had no idea that it was as bad as it was in much of the country. And so therefore, the ones that were getting sick or getting tested were typically already severe cases. That's what was leading them to go and even find a test and get tested to begin with. And frankly, a lot of them were already going to the hospital because of their symptoms. Their symptoms were so bad, they were just rushing to the hospital, and then they were getting tested for COVID at the hospital. So the initial line in March, in terms of the new diagnoses of COVID and the hospitalization and then the deaths, were pretty close together. But like I say, that now a lot of these people who are testing positive are probably a lot of the lower risk people. And that's because they felt that they were lower risk, and that's why they were venturing out more. And now they're going to be going home. And we always recall that we're worried here in public health about chains of infection. It's not just the individual, but it's now all of the new chains of infection that are going to be growing because of all these new people that have been infected. So if each person infects an additional person or an additional maybe 1 to 2 people, depending on the effective R ratio, the reproductive rate that we're talking about now, then the chains of infection will continue to grow. And indeed, in these places, the hotspots that we're seeing around here, clearly it is growing. That means that the reproductive rate is above 1, and that means that there are chains of infection, and on average, each of these people are going to be infecting at least 1, maybe more, at least 1, because then we know it's increasing. If it were 1, it would be staying roughly the same, but maybe as many as 2 people or more in each of these states.
How are they doing, Glenn, with test tracking and tracing, you last week you showed us this chart where New York got like 100%, got an A+ in this area. New Jersey, I think, was at like a 24% or something like that.
Yeah.
How has that changed in any way? Has New Jersey improved, number one?
Yeah.
And Florida, Arizona, are they catching up? I think they also were rated very poorly.
So yeah, so as a matter of fact, here are the ones doing really well now. So we're looking at Massachusetts, New York, New Jersey, and Michigan are doing great. New Jersey now is contact tracing 100% of the people who test positive. So this is great. So that means that our numbers, our cases continue to decrease. Anyone that tests positive, we can now, there's teams of people who are working to ensure that everyone around them who they might have come into contact with is tested and quarantined if they turn out to be positive. We're doing a lot of testing now, and so you can see the positive test rate is very low, which means we're testing just a lot of people, and in order to hit that few number of people who are testing positive. And we have a lot of capacity to spare in our hospitals. So New Jersey is good. If things were to go bad, we have a lot of room where we don't have to worry on the short term in terms of our hospital capacity, and we're doing really well in New Jersey right now. Some other countries or states rather that I was just talking about, so Arizona is an example. This is red. In addition to it growing, in addition to the positive test rate and them not testing enough, they're also approaching a critical point for their hospitals because they're at 72%. So again, let's compare New Jersey to Arizona. New Jersey was at 25% of its intensive care unit capacity, and Arizona is at over 70%, was 72%. So they're going in the bad direction. It's getting worse, and they are heading towards capacity. So at some point, their hospitals are just going to overflow. And so the question, so that's going to be this idea of between a rock and a hard place. At some point, the politics is going to say, no, don't lock down. But on the other hand, their hospitals are going to start to overflow, and they're going to start to see a much bigger burden. And it's really going to be interesting to see what they decide to do. And you can see that they're virtually not contact tracing at all. Their testing is poor. Even if they did contact trace, because they're not testing enough, they wouldn't even be able to handle the ones that they are testing. So they're in trouble. There's a bunch of other states that are also in trouble. You can see Georgia, Alabama, Missouri also struggling. They're struggling for different reasons, but tend to be similar. You can see that Alabama does have more capacity with its intensive care units, but they're not. But the growth rate is, the reproduction rate is growing. The positive test rate is too high. That they're not testing enough. That they're not contact tracing. So it's just out of control there. So it's problematic. You're on mute, Beck.
Oh, thank you. Okay, so let's talk about blood type. Do you know your blood type, Glenn? I know mine.
I am AB positive.
Are you really? I'm A positive. Can you tell everyone else in our audience knows their blood type? Perhaps.
O positive.
O positive. So can you
universal?
What are we hearing? We're hearing about in the news about blood type and some kind of impact based on disproportionate impact based on different types of blood. So tell us, please.
Yeah, so this is a general audience, so I'll just review what blood type is. This was found many years ago. I should have gone into the history. I'm sorry I didn't dig deep enough. But basically, there's two types of proteins on the surface of blood generally. And so these are either A or B. And so you can have, and then if O is if you don't have any of these, either of these antigens. And so if you can have an A, two A's, an AO, or so it's because you have two sets of genes, because we know we have chromosomes and they're matching. So it's any combination of A, B, or O. And so these are the concentrations, or the distributions rather, within different ethnicities in the United States. And so you can see that O, because it doesn't have these antigens, is sometimes considered the universal donor, because people who get the wrong blood type donated to them, they have an immune reaction because the body identifies it as foreign. So O has neither A or B on it, so they're considered universal donors. AB is considered universal acceptor because they can receive blood from O, A, or B, and they're just fine. So we're the lucky few. You can see AB tends to be around 4% of the population. It varies a little bit based on race. O is a lot more common, and A is a lot more common. And so, but again, it does vary. So it's interesting that blood type, see, I've been skeptical of blood type and disease for a while because there were some really bad studies that were done over the decades looking at blood type and various disease states. And because it's very easy to study, you can look at people's blood type and see, but the problem was that it tends to, because there is variation by ethnicity and based on other factors, I sometimes didn't put a lot of weight into some of the studies that were looking at blood type. When this was first reported, there were some early signals that were reported in Asia. I didn't really pay much attention to it just because, like I said, I didn't really trust much of the science that tries to look at blood type. It was almost like astrology, it seemed like, or like a fake science, and for me in some ways. So I tend to be skeptical of it. But what was interesting in this, there've been some follow-up studies. What was interesting is, so there's this genetic study that they were looking at, and they looked at variation in different genes of people who had severe disease versus those who didn't. And there were a couple genes that really started standing out as being indicators of being at high risk. One of them was a cluster over here of various genes that I don't know a lot about, but it's interesting because they're currently being investigated, and they might be therapeutic targets at some point. So that could be interesting. But also interesting in this was blood type came up again as potentially an indicator of severity. And so when they evaluated this, what they found was that people with type A were at way more risk than these other blood types for having more severe disease. It's still interesting, not quite sure what to do with it, but it's still interesting. AB also, which I am, also seems to be at higher risk, not as much as someone who has A alone, but A is probably a combination of both AA and AO. So I would suspect that AAs would be even higher risk than AOs. But you can see the ones who are at the least risk, it might even be protective, are blood type O. So people with blood type O are far less likely to have severe COVID-19 symptoms if they do get infected with COVID, which is great news for some people. Yeah, and that's it for blood type.
That's really interesting. I want to know how you got the AB blood and I only got the A blood.
Well, because you get one from one parent and one from the other, and then it's just.
And I'm only joking, but look at how you're more protected than I am. Okay. So be it. Anyway, thanks for walking us through that. That is really, really helpful. So you mentioned that we might find ourselves in another lockdown come the fall. You're thinking perhaps October, November. Do you kind of anticipate that could be nationwide or just in some hot pockets that would develop?
Yeah, I mean, the reason that a lot of us believe that we're going to see another severe outbreak in the fall is because in the fall, not only did we see seasonal variation in the reproductive rate, so it's much more contagious in the fall and winter. And so summertime, it's still spreading, as you can tell, but it's not as contagious as it is in the winter because people spend more time indoors and for a variety of reasons. But also in the fall and winter is flu and cold season. So right now we're not in flu and cold season. And the problem with flu and cold season is that those diseases present their own indications. And so for instance, when people have a cold and get the flu, they might sneeze a lot more. And so right now we're talking about COVID-19 where people might cough, but it might not go very far when they're coughing. But if they're sneezing, it might propel way further across a room. And so there's nothing about the flu or colds, as far as we know, that protects someone from getting COVID-19. So we fully expect that people can get both at the same time and be in bad shape. And so then in addition to spreading it more and it being even more contagious, like on steroids of what COVID-19 would be on its own, then we suspect, because they're impacting different parts of the body in different ways, they have different physiological pathways in terms of how they're doing their harm, then people who are co-infected might be at even higher risk of morbidity and mortality than they otherwise would be. And so this is definitely a fear of ours. It might not turn out to be the case. Maybe we'll find out that there is a protection for some reason. I mean, it's not something that we would believe that there would be, but you know, this disease again is still so new. We just don't know. There was a little bit of overlap back in March and April in terms of cold and flu, but it didn't overlap enough for us to really know what that overlap is going to look like. And so come fall and winter, we still don't know.
So,
but in terms of the states, yeah, go ahead.
yeah, no, but so sort of as a follow-up, did the lockdowns work? Was it worth it? You know, if we find ourselves in this place again come fall, was it worth it? And will people really feel that it will be necessary?
Yeah, so I keep on revisiting this chart. So this is back from March. It was generated by the New York Times using cell phone data, and it was a representation of how far people were generally traveling. And what they did was they compared counties across the country that had lockdown orders with counties across the country that did not have lockdown orders. And as you can see, if this is 0% and this is 100% lockdown, the ones with stay-at-home orders on average were roughly, what is this, 80, 85% lockdown. So there was still some movement. People were still going to the Amazon manufacturing facilities. The post office was still delivering mail. People were going to the hospital. So like there was still some movement. It wasn't a complete quarantine. But interestingly, even in counties that were not locked down, technically, like the states and the counties did not force them to lock down, they still were under lockdown 65% or so, whatever this number is, between 50 and 75, looks like around 65%. And so there was severe reduction in travel during that time among the counties that locked down, or rather that did not lock down. And so the question is, how much are people traveling now? And how much will their travel change if there's a lockdown versus not a lockdown? One way of evaluating this, and this was an early study, I haven't looked more recently to see if there's anything in terms of looking at more recent weeks and months. But so this was going until the end of April or late in April. And they were comparing adjacent counties that happened to be in different states across the Illinois-Iowa border. And so they were looking at 15 counties on the border between those states. Illinois had a lockdown, Iowa did not. And you can see that it had a massive impact in terms of the number of cases. And again, going back to this graph, this is not lockdown versus no lockdown, because you have to remember when we're talking about no lockdown, that's still essentially we're talking about a 65% lockdown, because even though they had no formal order, they were still hugely reducing their movement, and a lot of people were staying home. And so even with this, comparing the 65% to the 85%, you still see a massive change in the number of cases that were infected during that period with symptoms. And so this demonstrates, and every study that I found that's been investigating this has continued to demonstrate the strong power of the lockdowns. And again, the way I interpret this data is that even counties that did not lock down benefited from the counties that did lock down, because simply the communication to lock down and the worry about locking down penetrated to all of these other counties that they changed their behavior to. So the counties that did not lock down were not just out at bars and out partying. They were pretty locked down too, just not quite as much as the ones that had technical orders. So I would say that the lockdowns, without a doubt, the lockdowns had a really important role. And there were a bunch of important reasons. The first one was at the time we really didn't know what was going on, so it helped to just suppress the spread around the country. The second thing is that it gave us some breathing room in the hospitals, because some of the hospitals we anticipated were going to start to overflow, and we needed to prevent the beds from overflowing in terms of the number that reaching the capacity. And then third, it gave us enough time to get our testing and contact tracing up to speed. And so we know that a lot of states did not take advantage of that time to get testing and contact tracing up to speed. But in the Northeast and some of these other areas where we realized how bad it was, so New York, New Jersey, Massachusetts, we were hit really hard. And so we took that time with the lockdown and invested it all into getting our testing and contact tracing up. It would have been great if we had additional leadership at the country level, so that we had more testing and contact tracing around the country where we need it. But now here we are reopening and we are not there. And it's not just epidemiologists who can look at this and know what's about to happen. In the next month, 2 months, we're before then, we're going to see some pain, not just in these countries, but when you look at these other dashboards, not this one, this one. So this is I come back to this one occasionally. What I like about this website is they use the specific criteria that the federal government, that the CDC put out, or rather the White House in coordination with the CDC, of what we should be doing in terms of our own scorecard to ensure that we should be opening. And the red are states that do not meet those criteria. And so you can see in the South where we're being hit and in the West where we're being hit. So according to the White House's communicated rules that they've made clear, there weren't very many, according to those rules from the White House, these states should be in lockdown. However, according to the communication coming from the head of the federal government, they're having rallies currently, and so they are not consistent with the rules on their website that they've put out. And it's problematic. We don't have the coordination in the leadership to address this problem that we're seeing. Some states are doing great. Look at all there are a few that are in green. The states have taken the leadership and are doing well. Unfortunately, there's a bunch of yellow, and really unfortunately, there are quite a lot of red.
Well, hopefully by next week we'll see more green, because if I'm correct, we're seeing more green this week than we did last week. Is that right,
We
Glenn?
are. That's right. New Jersey got its act together a little bit more. I think Connecticut, I'm not sure if they were last week, but they've increased their testing. There's definitely some improvement around the country. So hopefully we'll see some more improvement. Hopefully, I think that the Midwest, although I mean it's unclear. I mean, hopefully you're right. We'll start to see some more, but based on what we just saw, not that one, this one, the Midwest had been doing better. Like, so the Northeast had been coming down and the Midwest had been coming down, but now there's a little bit of noise in that last week, and I don't know if this is just a blip for a week or if they're at a turning point right now and they're not going in the right direction. But we'll know more next week.
All right. Well, I know we all will be hoping to see more green. Those cards are very helpful. So, a couple questions about treatments have come in, and also questions about any new developments as far as vaccines. So we'll start with the treatments. A question about, can you tell us more about corticosteroid treatments, and is there anything we can learn there?
Yeah, so a variety of corticosteroids have been evaluated for COVID-19. I don't know if I'm going to very quickly be able to find this slide. Let me see. I should have brought it up earlier. Give me 1 second. So basically, as I'd mentioned in previous weeks, basically in the first week or two of infection, probably earlier. Here, give me 1 second to find this slide, because it is a useful slide. Here it is. All right, so first, there's typically no symptoms. And so hopefully we can, with increased testing, the goal is to identify people who are COVID-19 or rather SARS-CoV-2 positive before they have symptoms. Because if you can identify them first, then you can give them the pulse oximeters and you can identify them. So at the first sign that their symptoms might be getting worse, then they can immediately go to the hospital and start to get treated with our available treatments. And so hopefully some of these people now can start to get addressed within the first week. But early in the disease, antivirals seem like that would be an appropriate place to look for them in terms of using them. But then the problem is after the first week or so, when the viral load starts getting high and there's a lot of replication in the virus, then it's really immunomodulatory drugs that you need to talk about. You need to start tamping down the immune system, because in a lot of these patients, the immune system becomes a runaway train, and it's sometimes called a cytokine storm, and you have all of these factors that start to go crazy, the tumor necrosis factor, the interleukins, and all of these different inflammatory agents. And so one set of drugs are these things called these corticosteroids. And that is over here, where I just was, over here. And so so these are great. They've been around for many years. They're all generic as far as I can tell, or mostly generic, dirt cheap because of that, widely available. And so they would be great candidates. What we do know about corticosteroids, just because they're used so frequently, is that on the short term, they're extremely effective at tamping down the immune system very quickly. On the long term, or even the medium term, they are bad drugs in the sense that they're very destructive. They cause all sorts of damage to the body. So these are not good treatments for a medium or long-term solution. Like, this is not something that you would take prophylactically, for instance, because these drugs are dangerous and are not good long-term. However, on the short term, because they tamp down the immune system so effectively, there were some really interesting, or not just interesting, some amazing results that we're finding so far. And one of the things that they found is that among patients on ventilators, it reduced their mortality rate by 30%, which is huge. So all the people that were on ventilators that would have ultimately died, that we would have expected they would die based on the previous rates, 30% of them are now surviving. That's huge. Among people who are on oxygen, 20% of them are now surviving. And so we know, and so this is also huge. 1 in 5 patients who would have died are now surviving. We know that patients from COVID-19 die in a variety of ways, not just from lung disease, not just because of the ones on ventilation or oxygen. We also know that there's clotting problems, so people have heart attacks and strokes and all sorts of other problems that are not just lung related. So far, this drug was only shown to be preventive in lung disease, for the tamping down the immune system and preventing this lung mortality. So right now, when you look at the total mortality rate reduction, it only reduces the mortality rate by 17%, which is still amazing, still fantastic, because those 17% of the people are now alive, whereas, or will be alive, versus they would have died previously. And so what this means at a population level, so currently our best infection fatality rate estimates are probably around 50 to 78 out of 10,000 infected patients would have died. And now, if we make this standard of care for everyone who's on a ventilator or requires oxygen, then that means now it's going to bump it down, and it's now more likely 42 to 65 out of every 10,000 infected patients will die. This is still quite a lot of people, but if we can just incrementally keep on lowering it, then by the time we hit fall and winter, we'll be in pretty good shape. Where it's still going to be a tough disease, but that won't necessarily be the pandemic that we're worried about with the severe morbidity. And that is something I need to bring up. So morbidity versus mortality. So right now we're talking about mortality. These are people who are dying. People who live still have long-term consequences, and there's a lot of long-term consequences. And maybe we'll get to that later today. But just because someone who's on a ventilator ultimately lives, they might be alive with a lot of scar tissue in their lungs and other things that will dramatically increase their burden and the cost of care throughout the rest of their lives potentially. We don't know what the duration is. For some people, the scarring might heal. For others, it might last. But the recovery process is not immediate. Just because they survive, it's still going to be a long road for a lot of people. But this is good news. That we're reducing the mortality by 17% overall is really good news.
That's great news. We always like hearing good news from you, Glenn. keep bringing that good news to us. So what about thrombosis in COVID-19? You talk about the effects of this corticosteroid, and that's incredibly helpful, but about thrombosis, can you tell us more?
Yeah, so it's kind of weird. So thrombosis, whenever we talk about a thrombotic event, that's a clot, where the blood clots. And there's a bunch of different pathways in terms of factors that are involved with blood clotting. And there's a lot of anticoagulants on the matter to address blood clotting. So for instance, clots can cause heart attacks and strokes, pulmonary embolisms, deep vein thrombosis, depending on where the clot clogs up the arteries and the veins, that can cause all sorts of problems throughout the body, major problems we're talking about. And so one thing that we found is when you look at the cadavers, when you look at the corpses of people who have died from COVID-19, there tends to be tons of these clots that they find in the lungs and around the lungs. We don't know if the clots are forming in the lungs and then just traveling around the body, or whether the clots are just forming in different places around the body. Right now, our best guess is that really this is looking more and more, rather than it being a lung disease. We first called it SARS because it was severe acute respiratory syndrome, but that was just the first set of symptoms that we found, and that's why we identified it so quickly and called it something and rang the alarm bells. But now we're finding, and I mean, we've known it for a while now, for months since we've been following it, but more and more we're starting to investigate it, and we're realizing that this is really a multi-organ type of disease. And so this ACE2 receptor occurs all over the body. And one of the places that it occurs is in the vasculature lining. So the cardiovascular system has these skin cells that line the whole, epithelial cells that line the whole cardiovascular system. And they are full of ACE2 receptors. And one of the key things that our cardiovasculature does is it helps to regulate the clotting process, so that if there's a cut, then it can very quickly, at the location where the cut occurs, start the clotting process and start to heal it. The problem is with SARS-CoV-2, it's now making the epithelial cells in the cardiovascular system go crazy. And one thing that we're starting to find is that 15 to 30% of COVID-19 patients have thrombotic events. So that includes heart attacks, strokes, and other clots that I mentioned. And this is quite large. So it really puts patients at risk. Right now, standard of care for most patients is to immediately begin on anticoagulant therapy when they get into the hospital. The problem is that the anticoagulant therapy is not working as much as we thought that it would, based on some of these other clotting factors that we've identified for typical clotting issues that we find in patients. There's some other proteins that we're finding that we don't really typically treat with our anticoagulants that we think are involved potentially in the cascade that's causing this clotting to occur. And so right now, this continues to be a major problem. It's a major cause of death. And so it's we're still following this up. And I was having a talk with my nephew this morning, where we're talking about causes of deaths of COVID-19, and people don't just die from respiratory stuff. So I want to keep on bringing this up. People with COVID-19 are having heart attacks, strokes, pulmonary embolism, other organ damage, and that's how they're dying. And it's one of the reasons that we're convinced that SARS-CoV-2 deaths are undercounted, because yeah, people would have had heart attacks otherwise, but this is increasing heart attacks. So if someone has a heart attack and they're found at home, typically you don't test the dead body to see if it has SARS-CoV-2 because that's a waste of a test. You wouldn't, it's a dead body. Why waste it on the dead body? And so if someone's had a heart attack, it's unclear whether it's listed as a heart attack on the death certificate or COVID-19 on the death certificate. And a lot of times it would probably be listed as a heart attack. So the only way to really tease this out is retrospectively. When we go back months into the future, we can look back into the past and see the total number of heart attacks. And we'd have a number of heart attacks that we would have expected just because the rate is pretty consistent from year to year, a little bit of movement, but we have high precision in predicting the total number of heart attacks that occur at a population level. And if the numbers are higher than that, and they're termed heart attacks but not labeled as COVID-19, then we can be quite confident that they were associated with the virus and not just heart attacks that would have happened otherwise. And so this continues to be an issue. It's something that's being investigated, but it's a serious issue. COVID-19 is not a lung disease. We call it SARS, but it's not just a lung thing. It's really multi-organ. It's really problematic.
So when you talked about how patients routinely are treated with blood sort of anticoagulants when they are admitted, what about questions has come in about the corticosteroid treatments? Is that's typically given when somebody develops lung issues or breathing?
Yeah, that's a good question. I'm not quite sure what the standard of care is. This was evaluated for other causes of death, and it wasn't found to be effective at preventing the other causes of death. It was only found to be effective, at least, and here's one of the problems. This was released by press release, so I still haven't seen any published study that indicates more of the details, and I'm always worried when something is released just by press release, because we've seen this happen over and over again with the malarial drugs and with other things, that a press release says, oh, eureka, we found something, and then the devil's in the details, and you read the study and it's actually not as great as they represented it. And so it's still a little worrisome that this is a press release. But the organization that was doing it, it was a well-funded study. It was something that I think the World Health Organization was involved in, but it was one of these major drug areas that had been investigated. So we do have confidence in the groups that were doing it. But what they found is that although it had an important reduction among people on ventilators and among people on the oxygen, it didn't seem to have any effect at all among people at preventing death among people who are not in those cohorts.
Thanks for clarifying that. So many weeks ago, you had made a prediction, so to speak, about the number of deaths that we might see in the US based on lockdowns and social distancing or not. And you had suggested that we might be seeing close to 200,000 sometime August. Is that are you still feeling confident with that prediction, or do you anticipate that might be low or high, or it could happen later on? What are your thoughts there?
Yeah, you see a curve like this, and it makes you hesitant to think, oh, well, how can there be so many deaths between now and then? But like I said, so I think that it might have been overstating it a little bit, but at the same time, like I said, when we saw this uptick here, this is at the country level, a lot of these cases that are now being diagnosed in the last week or so are the ones who identified themselves probably as being least at risk, because they were the ones who would have been the most likely to go out, go to the rallies, go to the Las Vegas and go out. So now that they're sick, that they're bringing home their chains of infection to their households and to other people. So I think that we will start to see more of an uptake in the mortality rate, not just in some of the states that we looked at. I mean, so we're still seeing a small increase in Arizona. We haven't really started to see a big increase in Florida, but I think that we will start to see an uptick. I think that based on right now, there's basically 4 new treatments that we have. So basically, this 0.64 infection fatality rate was before we knew anything. This was right at the beginning of the pandemic, and this was our best evidence that was coming out without any great treatments. So now we have basically 4 things that we can do. The first one, which seems so simple, and it is simple, but it wasn't part of standard of care because no one even thought to do it. What they found was that if there was a patient in a bed in a hospital, if you turn them on their side, then they were much more likely to survive because it was easier for them to breathe than if they were laying on their back. Normally in a hospital, you imagine people are laying on their backs. That's typically just how they're laying, just because it's easy to treat them when they're lying on their backs. But it was found that if you turn them on their side, that makes a difference. So that's one thing that could reduce the infection fatality rate from what we're seeing here. The other thing is this corticosteroids reduces it. The other thing is the anticoagulants could be reducing it. And then finally, oxygen. If you give them oxygen earlier, that seems like it could be having a beneficial effect. And that's one of the reasons why the pulse oximeter is helpful, because then if you identify earlier that you might be having symptoms even before you have major symptoms, it's more of a sign when you have the pulse oximeter rather than a symptom, which is something that you feel. And then the other thing is we also have remdesivir, which is an antiviral. It's found to be a little bit effective, but not hugely effective. But between all of those, so I guess those are 5 things. Though the infection fatality rate is going to be lower than what we're seeing. It's still going to be high. So 0.53 as an average is still going to be high. Whether we're going to see 200,000 by August completely revolves around whether the lockdowns occur or not and when they occur. And that's as simple as it is. These states that where we're seeing the numbers just start to rise, there's political motivation in some of these probably to not lock down. And I don't know what that's going to look like, but that's what's going to determine everything. If they lock down, then lives will be saved. If they don't lock down, then there will be more mortality.
Thank you, Glenn. We've spoken in weeks past about vaccines and different vaccines out there around the world, and you walked us through what it meant for these vaccine trials to be at different phases. Can you are there any updates that you've noticed or seen in the past few weeks that maybe might make one or more of these vaccines look to be perhaps promising?
Yeah, so not really with the vaccines. There's a variety of approaches that they're looking at right now. There are different receptors that have been identified. I don't know if I pulled out any slides on this. I don't think I did. But so there's basically, I'm not going to be able to tell you what the receptor is just because I can't, off the top of my head, pull it out. No, so all I'll say is, so the primary one that they're focusing on are neutralizing antibodies for the ACE2 receptor. But there are a couple other receptors that have been identified, including, I can say one. So I mentioned in previous weeks this idea of ADEs, where there might be an immune system reaction that goes out of control. And that's based on this FC receptor, which I mentioned earlier, why we need neutralizing antibodies and why there's a risk here of FC. They've been doing a little bit more work on this, and they have found that when you compare COVID-19 in adults versus kids, adults are more likely to trigger this FC receptor, whereas kids don't seem to be triggering it. And flu, when you compare flu to COVID-19, a typical flu year doesn't trigger the FC receptor. So we have verified that SARS-CoV-2 is associated with the FC receptor. We don't know what this exactly means. So it could be good, it could be bad, we don't know. The worry with SARS-CoV-1 was that it was bad, and that people who had a stronger antibody response were actually the ones who are most likely to get sick and to potentially die. And so we don't know if that's going on here, so it's still an unknown. With the vaccines, I don't have much more information here right now. It's just that they're still early in the trials. We know it's going to take months. The ones we might see earlier are the ones I talked about in terms of polio and tuberculosis, where those vaccines had been around for a while. And so we understand their safety profile. And now we're looking to see if there are some broader immune system benefits rather than just the antibody mediated ones. There is one thing. Let me see if I can pull that out real quickly. Oh, I don't know if I'll be able to find it too quickly. It's this idea of vaccination hesitancy. Let me see if I can find it, just because it was an interesting idea. Where was it? Oh, I'll get to it in a little while, I guess. But there's this idea that maybe this was it. Vaccine hesitancy. So the worry is that there's a lot of anti-vaxxers out there. But in addition to that, the safety profile of these coronaviruses vaccines, if they are released, is still not going to be 100% sure. And so a lot of us might be worried that even if it's proven effective, if we don't know what the 1 or 2 year or long-term consequences of the vaccine are, then might be some worry in terms of the long-term safety of it. And so when you're looking at vaccine hesitancy, they've surveyed to see what percentage of Americans would take the vaccine if it becomes available. So the SARS-CoV-2 vaccine, if it were available today, or if it were available in November, what percentage would take it? And so far, surveys are suggesting that only 30% of adults would get the new vaccine as soon as it's available. And so that's not enough for anything. It's not enough to prevent herd immunity. It's really not going to be very helpful to the population. So even if the vaccine comes fast, this vaccine hesitancy is going to be problematic. And I don't even know what to say, because I know personally I would be worried about safety. We normally look at it, normally it takes 5 to 10 years to bring a vaccine to market. And one of the reasons it takes so long is because we're looking at the safety of it. And we found that some vaccines are unsafe, and you don't realize it until people are re-exposed to the virus a few years later, and then you realize that the vaccine has triggered their immune system, which is what I was just talking about with these ADEs, these adverse events. And with a few months of data, it's really going to be hard to have a compelling safety issue, or to evaluate safety sufficiently for a lot of us. So it's a tricky thing.
Yeah, that definitely is. I can definitely relate to that feeling of being hesitant, even if there would be a vaccine available at this moment. So an interesting question came in about influenza, and with people practicing good hygiene, and Harry, this was a great question. Thank you for this. If with people practicing good hygiene and now wearing masks and doing all these things that we don't typically do during a flu season, why do we have to worry about influenza quite as much? I mean, wouldn't we expect that actually perhaps as long as those who normally get the flu vaccine, and we're doing everything that we're supposed to, we're back in Vegas, that we're supposed to be doing, might that actually help with the spread of flu?
So I would say yes, definitely it would for most of us. But these people in Vegas are not going to be helped at all. And so it's problematic. I think that if kids return to school in the fall, then it's going to spread through the kids like it always does. If in the fall we find ourselves staying at home, or the kids staying at home, in addition to all the people working from home, the only way that's going to actually happen is if we're under lockdown. But if we're under lockdown early in the school year, then we probably will not see the spread of flu, and we won't have to worry about it nearly as much. But it's going to be really hard politically. If the amount of virus spreading is low in September, October, say in the Northeast or in the Midwest, where we've been doing somewhat well, it's going to be hard for the states to electively choose to lock down when we have the virus under control. And if that's the case, we're probably going to send the kids back to school, and then we're probably going to see the cold and the flu. And it's going to be probably less than a typical year, presumably, but it's still going to spread. And there's a lot of the population. I mean, President Trump, I think at some point over the last week, mentioned that if people were wearing protective masks, that was a sign that they were against him. And I mean, it's absurd that people would choose to protect themselves as a sign that they were politically against whatever Trump might be believing. But it's worrisome because then people who do support him might believe that it's better to not wear a mask and not protect themselves as a result. And so then they'll be susceptible to flu, cold, and coronavirus, and it would be problematic.
Do we have any reason to believe, a good question just came in from Sandy, that the flu vaccine may not be available at the same levels as it has in the past, or any early indications about the availability of the flu vaccine for this fall?
Yep. No, I don't have any reason to think that we'll have less. I think that they're going in just the opposite. I think that we're going to be encouraging people to get vaccinated for flu earlier, and encourage a much higher amount of vaccination. Vaccination coverage last year was only around, or 2 years ago, 2018 to 2019, was only around 45.3%. And so we're going to try to up those numbers considerably going into the season, just because we know that the overlap is going to be important. But I don't think there's a worry at this point that there be some constraint, some limitation in that vaccination. I mean, maybe, I guess your idea is that if we're spending all of our resources on evaluating these other vaccines, that we wouldn't have enough resources for the flu. I don't believe that would be the case. I think that there's enough urgency with the flu vaccine that's recognized by the public health community that I'm confident at this point that we'll have enough.
Well, that's good news. Another piece of good news. We like hearing good news. So I think we're just about toward the end of the program. I know we ended with good news a few weeks ago about the dogs who were able to sniff out the virus. Do you have any other good news that you can share with us today, or can we?
I already spent it. I already spent my good news. The corticosteroid was the good news.
All right, we'll take it.
I have a couple of other interesting things I could talk about if you want, that I found really interesting this week.
Okay.
One of them, I don't know that this is good news though, so I prefaced it. So the prison system has been hit pretty hard by COVID-19 because the inmates are locked in. There's not much that they can do, and so the SARS-CoV-2 has been spreading a lot in the prison system. But as epidemiologists, obviously we don't want people to get sick or to have serious consequences or die. But interestingly, it's a petri dish for us to study. So we have this idea of herd immunity, and if herd immunity was really protective, say at 50% or 60% levels, then you'd expect when 50% or 60% of the people got infected that they protect the other people, and that you sort of have a prevention in terms of ultimately the number of people getting infected. And the highest number that we've seen so far in a prison was in this one prison in Ohio. 81% of inmates got infected. So we know that the ceiling, or that the ceiling is at least 81%, because maybe it would have continued to get infected. The population would have continued to get infected after the tests were given that identified it and published it as 81%. So this is worrisome that it went up that high. Other populations that I'm looking for are in the homeless population. They're also getting hit really hard by SARS-CoV-2. And so I'm looking to see what percentage of them at these different facilities for the homeless shelters, what percentage among people who go there to sleep and who regularly visit them, what percentage of them have serological results suggesting that they were ever infected. And it's right now there's just not a lot of data out there. People aren't presenting it. There's not enough testing being done, and even when they are testing, they're not reporting it. So we don't have visibility into what's going on right now, which is so disappointing. Because if we had a lot of these studies being reported among prisons around the country, among these homeless shelters, we could get a much better idea of what herd immunity is going to look like. One thing that I can show you is here. So this was worrisome. So I can show you this example. So first I'll go back to what we were seeing here. So I like to sometimes show other countries. I mean, you saw US, we talked about, where the US was up we weren't doing very well bringing it down, but it was slowly going down, but now we're going up again very clearly. Other countries that we've been looking about, or talking about rather, and looking at are Brazil and South America. And you can see that Brazil is doing really poorly. Another country that I hadn't been talking about very much is Chile, and also in South America. Whoops, Chile is over here. And look at Chile, it's just going up. And the problem in some of these places is that the testing is poor and it's hard to know what's really going on. But when you look at Chile, so here's the United States. This is the cumulative number of confirmed. So this is a SARS-CoV-2 test, confirmed positive test, COVID-19 cases per million people. United States, you see where we are. This is the cumulative. So that's why the shape is different than what we saw before. Sweden, you see, is despite their laissez-faire approach, is continuing to go up, and almost as much as the United States, but not as bad as the United States, because our laissez-faire is not the same as Sweden's laissez-faire. And in states in the United States where we're being hit hard, like Arizona, they're frequently just not wearing masks. They're just going out and are not doing social distancing. In Sweden, they were very sensitive to going out, and they're in recent weeks they've started to have more contagion, but they were much more sensitive than laissez-faire in the United States. But what you see is Brazil is starting to come up very fast, so they're going to surpass the United States at some point, probably within a few weeks. But Chile is interesting because it's going up so fast. Chile is probably at this point going to be one of the first countries to tell us what the herd immunity level looks like, because the contagion is going so fast around the country that at some point they're going to reach, if herd immunity exists, they're going to reach it probably before the end of the summer. Other countries in South America are also going to be approaching it probably by the end of summer as well. And so Brazil we're looking at. Argentina is increasing, but not quite as fast as Brazil cumulatively. Although when we look at the 7-day rolling average, or going back to what we were just looking at, you can see here Argentina, even though it has less as a percentage, it's the rate, this incline is still very steep. So Argentina is going to be catching up to Brazil and Chile within weeks or months. They're further behind, but the rate of growth is not good. But going back here, so what this looks like is you can see some countries we've been talking about. I also put Australia in as a comparator, and that's because Australia, which has a larger population than Chile, has done a much better job of keeping it under control. So Australia, because this is not the case that like it's inevitable the countries do poorly. Like some people think, well, why bother locking down? Because eventually everyone's going to get infected. But that's simply not the case, because Australia, they locked down at first, but now they're not locked down to any near extent of what they were back in March. And they're doing quite well. They had 16 cases. They're a country with roughly 25 million people, had 16 cases yesterday. And so they're doing quite well. When you look at the total accumulation, Australia is doing extraordinarily well relative to other countries. So this is a disease that can be dealt with well. It's just that a lot of these other countries are not doing it well. Canada, I put on here too, that came up a little earlier in the conversation. Canada tends to be doing quite well cumulatively when compared to other countries here. When we look at Canada here, they are, I think they were yellow. They might not be yellow. No, they're red, but let's see where they are. So Canada had the early bump up, and then they've been coming down. Right now, there's a little bit of noise. We don't know that now that they're like more open as a society, is this going to be something that continues to go up? Do they have contact tracing and testing in play? I don't know exactly what it looks like. I'll look at it for future weeks. But you can see that they had 388 cases in the recent day, which is an order of magnitude smaller than the US, where we're talking about almost 25,000 cases yesterday alone. That's a lot. Let me see, there's one other thing. Whoops. All right, one other thing I just can point us to, and that is long-term consequences. I'm not going to talk about long-term consequences in general. There's only one type that I'm really interested in right now, and I'll leave it with this because it's already getting late, so we can talk about other long-term disabilities and consequences that have been studied next week maybe, if people are interested. But for now, this question of what does it mean to be asymptomatic? And so the asymptomatic folks, so again, these are people who are tested and are found to be positive with SARS-CoV-2, but they don't have any symptoms. And so a lot of study has been trying to find out, well, do they have any clinical disease, or do they produce antibodies? And looking at all this, and there's a few interesting things that we found. First, clinically, one thing that we found that's so important and that's going to be followed up in other studies is that asymptomatic does not mean disease-free. And what we're finding in one of the first studies that looked at this is that around 40 to 45% of asymptomatic, so these are people that never developed symptoms, but they were infected with SARS-CoV-2, 40 to 45% of them developed these ground glass opacities that were found in the lung, So they are having clinical disease. They might be having breathing issues that they're just not aware of, and that's why they're asymptomatic. They might be having other diseases. I mean, their clotting might be going on. We haven't investigated that enough. They might be having an increased risk of stroke and heart attack and other clots, and we haven't investigated enough. But the fact that they are having severe clinical disease, that in 40 to 45% of them, these opacities are found, that's worrisome. And then even worse, these folks on the Diamond Princess cruise ship, if you remember them from earlier in the year, they were one of the first set of people and that were Americans that we found to be looking at in terms of their disease, and they've been followed up, and around 55% of those people who are asymptomatic turned out to develop these lung lesions. So no symptoms, but they had these lesions. So we don't know, is this going to develop scarring in all these asymptomatic people, or these 55% of asymptomatic people who have these symptoms? Will the scarring heal? These lesions heal over time? We think that most of them will heal, but again, we don't know what the consequences of this are. And so this brings me back to end. Well, I'll say two more things, and then I'll end it. But so the first thing that we found is that the antibody levels. So an interesting thing is that the antibody levels, although they occurred in the asymptomatic folks, so if you do widespread antibody tests, you should be able to find a lot of them. What we found is that the antibody levels were a lot lower than the ones who are symptomatic. So the pink was the symptomatic, the blue was the asymptomatic. And similarly, asymptomatic cases in this small sample, pardon me, there were only 37 people in each of these wings, or each of these arms. The asymptomatic cases tended to shed virus longer than the symptomatic cases. So it could be because the symptomatic cases had a stronger immune response and a stronger antibody response, that they were able to shut off the viral shedding sooner than the asymptomatic cases. And so my point is that asymptomatic does not mean disease-free. And so we've been focusing, because we've been in the thick of this major outbreak, this major global pandemic, most of us have been focusing on mortality, simply mortality. Are people dying? And this morbidity is also an issue. Among people who are infected, even the asymptomatic who don't realize it, there is clinical disease going on in a lot of them that they just don't know. We don't know what the medium-term consequences of this are. We don't know what the long-term consequences of this are. And so that's why when we're talking about reopening, when will this be over, these are things we really need to get a better handle on understanding before we can say all clear. So even if we start developing better medications to prevent mortality, we really need to get a better handle on this morbidity. And so it's being studied, where there's a lot of work that's investigating this stuff, but it's something we can't stop talking about. It's morbidity and mortality, not just mortality.
That is outstanding, Glenn. I mean, it's really unbelievable. I didn't even think about this type of results that you could present to us, but thank you for bringing this to us and to show us that asymptomatic doesn't necessarily mean asymptomatic, and it's shocking. And
it just means no symptoms. It doesn't mean that there's nothing going on in the body with the virus.
Wow. Okay, we thank you. as always, for
You're very welcome, as
sharing
always.
your time and your expertise with us, Glenn. You have been stewarding us through this journey. And I have to say, we all look forward to our weekly conversations, both live and those who follow up on YouTube later. So really, even though some of this data you're presenting is slightly frightening, it's better to be in the know than not. So we thank you for that.
Thank you very much. I look forward to it every week as well. It's always a pleasure.
So can
Thanks everyone for joining.
Same time, same place next Sunday?
Next Sunday, 7 p.m.
Excellent.
Eastern Standard Time.
Wonderful. Everybody be safe, be well, wash your hands, wear your masks, and we look forward to seeing you next Sunday. Have a good week, everybody.
Thanks everyone. Bye-bye.
Bye-bye.